Assalamu alaikum. Good morning, good afternoon, and good evening, depending on your time zone. I hope everybody is doing great. Okay, so welcome to the last lecture of tonight, which is going to be about the orthopedics imaging. Tonight, we're going to cover the imaging, which is going to be the last lecture of orthopedic and rheumatology. All right. Okay, so a few things. Today, we are going to focus more on MCQ1 aspect of the imaging, and we are not going to cover the NAC OSCE aspect of imaging for the orthopedics. Again, for the NAC OSCE, if you're doing, you might get a station that they might ask you that you have a patient, for example, 40 or 45-year-old male who has back pain. Please take a history, do a physical examination, and answer the examiner question. So when you go inside, you take the history. Once you're done, then he's gonna ask you to, obviously it's a combo station. You have to do a physical examination based on the history finding, and then you need to do the examiner is going to hand you a X-ray. So now you have to match this X-ray finding with the physical examination and then with the history finding. And based on that, you decide what is your diagnosis and what will be your approach for the management of this patient and what are the steps to be taken in order to have a proper and a healthy and a professional regimen management approach. All right, so today we're going to focus more on the MCQ1 aspect of it. So for the exam in MCQ1, how MCQ1 tests orthopedic imaging. So the first and most important thing for you as an IMG when you have a station should be that, is the imaging needed for my patient or for this condition or for this clinical vignettes that I'm doing? Is it needed or not? And if it is needed, what is the safest imaging? Which in most cases, it might be ultrasound and X-ray. And X-ray would be more for the orthopedics, right? So recognize the red flag. If there is a red flag, obviously you have to include the imaging. If it is not, most of the time you don't have to unless you suspect fracture, suspect dislocation, or suspect an infection and inflammation. Avoid unnecessary MRI, obviously. We don't want to use government money for no reason, and also expose the patient to unnecessary investigation. Choose urgent aspiration or reduction when needed. So now for the station tools when it comes to imaging. So X-ray first for suspected fracture and dislocation. Any trauma that causes the patient pain and discomfort that the patient cannot move certain part of his body should raise an eyebrow that this might be a fracture or dislocation, especially if it is a joint. Then in order to make sure that your next step is going to be the safest one, so you need to do the X-ray so that it puts you in a better position to decide and go ahead for the next step. So MRI usually is not the first best imaging unless the X-ray is inconclusive or the X-ray is not giving you enough information to go ahead and do the next step. So, I mean, the reduction or whatever it is, or do the surgery. So MRI is the best choice when there is an occult fracture, when there is an abnormality or disorder or damage or injury to the spine, when there is a infection, when there is a malignancy or internal rearrangement. Other rule, we have ankle, foot, and knee. We have already covered the ankle and the foot, but we haven't covered the knee. That today we're going to cover it, but we're going to very quickly cover the ankle and foot as well. Red flag safety triggers. Now, best answer mindset. Ask, is the limb ischemic? So the patient has a trauma. Do I see the symptom of ischemia? Is the joint affected? Is the spine compressed? Does a clinical rule requires an X-ray? Do I have to? These are the best mindset that you need to have whenever you're approaching any patient with orthopedic conditions or rheumatology. Clinical rule reduce unnecessary imaging, but red flags always take priority. So remember that. Always check for the red flags. You cannot afford to miss the red flag. If you miss the red flag, trust me, whether it is imaging, you get the wrong one, whether it is management, you get the wrong one, whether it is a treatment or and a follow-up, whatever it is, you will get it wrong. So do not miss the red flag, especially if you're doing a Nakoski station. Now, imaging hierarchy, choose the right first test. If it is danger, first, obviously, we have to do the ABC like every other emergency case and neurovascular. X-ray is first for suspected fracture and dislocation. MRI, as I mentioned before, that if it is occult, and if it is soft tissue damage, and if it is a spine, malignancy, infection, internal derangement, then you got to go with the MRI. Or if the X-ray is not giving you enough information to decide for the management. Aspiration of the hard joints and no imaging, low risk mechanical. If someone just comes with, let's say a younger patient comes with a lower back pain, a paramuscular strain, then you don't have to. You don't have to do any imaging, right? Just a conservative approach will be more than enough. So clinical situation, now this is how they're going to give you a situation or a clinical vignettes. For example, you have a patient who has a suspected fracture or dislocation. Plain X-ray. Why X-ray? Because I'm suspected to the fracture, I'm suspected to dislocation. Why is it so important? Why MCQ1 likes this to be tested? Because it is fast, it is cost effective, it's accessible, it confirms alignment and a fracture pattern. So it gives you enough information to put you in a better position to come up with the right treatment or next plans. So you have a negative X-ray, but persistent hip fracture concern. Even though the patient has a lot of pain and you're suspecting a hip fracture, you do the X-ray, but the X-ray is not helping you. It comes back normal. So should I just take it as it is, negative, and shouldn't do anything about the patient's complaint? No, I have to escalate it. Now it is the time to escalate the investigation. Go after MRI. Choose the MRI. Why? Because the patient has pain. I mean, the symptoms are there. The patient is complaining, and he has all the characteristic finding of a pelvic fracture, but the X-ray is not giving me the finding of the fracture so that I have to start my treatment, which is in most cases going to be surgery. So if it is not helping me, I need something better to give me a better idea or a better visibility to the injury. So you go ahead and do the MRI. Detects occult fracture and marrow edema, which is sometimes missed. In most cases, it will be missed by the X-ray. Back pain with a neurologic or infection, cancer risk red flags. So back pain, the patient has back pain, and the patient not only have back pain, the patient has neurologic or infection or cancer red flags. So any back pain with any of this will require urgent MRI. Back pain, only paraspinal muscle stiffness, you don't have to do anything. Back pain, the patient cannot pee, that's another story. That's emergency. You have to do MRI. You have back pain, but the patient lost sensation around the anal area and the space, the perineal area until the genital area. Or the patient has lost, for example, control of bladder or bowel, or the patient cannot feel the inner thigh. So these are the neurological findings. In this case, you cannot even delay it 1 minute. It's urgent. You need to order the MRI and you have to refer it for the surgery. Show canal, cord, cauda iguana, epidural disease. Acute hot swelling joint. What is it? Septic arthritis until proven otherwise. So how should I approach this? Arthrocentesis. So diagnose septic arthritis and crystal. Obviously, you have to do, because it's monoarthritis, you have to rule out the other condition which comes or present like monoarthritis, like gout arthritis or so to go. So Ottawa negative, mild ankle or knee injury, no initial imaging. So if it doesn't meet the criteria for Ottawa rule, just don't have to do any X-ray. Functional care with a safety netting. Do not use MRI as a screening test for every musculoskeletal complaint. Anyone comes with a pain in the joint, in the muscle, we don't do MRI. Use it when the result changes the management. We will do one by one, every single one of them in a specific condition. So X-ray first. In which conditions do we do X-ray as a first imaging? Now I'm going to give you some scenario or presentation. You have an old or elderly who had a recent fall. Now, after the fall, the patient has shortened, externally rotated leg. So what should I do? What is the issue here? Obviously, I am thinking about pelvic fracture. So if it is pelvic fracture, what can give me or at least help me to support my diagnosis, my clinical diagnosis? I need some support. X-ray, anterior, posterior, pelvis, and lateral hip X-ray. And most likely it's going to be hip fracture, right? If it doesn't help, then I'm going to do MRI. But in this case, first imaging will be the X-ray. Now, FOOSH, if somebody is falling out, outstretched hand, and then the patient develops a pain in the wrist. So obviously, history of trauma, the patient cannot move the wrist, which is one of the joints, right? Anything that's suspected fracture and dislocation, I have to do an X-ray, wrist X-ray, radius, distal radius fracture. It could be anything. So I have to do an X-ray just to make sure that it is not a fracture or dislocation. So long bone deformity after high energy trauma, bone X-ray, including adjacent joints. So long bone deformity after high energy trauma. If there is a long bone, the trauma happened, for example, you're sitting in the car, in the back seat or the front seat, you have a motor vehicle accident, and now the knee is displaced. We're not only going after the knee, we're going after the hip too. Why? Because it is high energy, which not only dislocate and affect the joints in the knee, but it will affect the hip as well. Because when you sit like this, when you hit, not only the hip is going to be displaced and affected, the hip will be affected as well. And also the ankle, right? So femur, tibia, humerus fracture, shoulder deformity after fall. Obviously, fall is a trauma. Any trauma, then after that, any joints gets hurt, what should we do? X-ray, dislocation associated, or probably there is a fracture as well. Focal bone pain plus night pain, weight loss. What is it? Constitution sign and symptom. The patient has night pain, the patient has weight loss, probably the patient is having pain also. With these are all pathological finding or constitutional finding. So for this, regional bone X-ray, and also most of the time it will be either the tumor, the pathological fracture, and along with other red flags. So documentation rule, record neurovascular stats before and after reduction, splinting, casting, traction. So if, let's say you have a trauma, the same scenario that I give you, you're driving, for God forbid, your patient is driving and your patient gets involved in a motor vehicle accident. Now the patient has a joint dislocation and probably a fracture. So before you do the X-ray, obviously if the patient is not stable, you stabilize the patient, ABC, and then you do the X-ray and neurovascular examination and check. Then you take an X-ray. Then you do the reduction. After reduction, you do what? Again, you check for the neurovascular and take another X-ray just to make sure everything is fine, okay? Hip fracture, X-ray first, MRI is occult. I think we did cover this. So the classic stem will be older adult, fall, groin pain, cannot bear weight, shortened, an externally rotated leg, pain with a passive internal rotation. Imaging sequences, the first step will be the X-ray. It doesn't help. What should I do? I'm going to do MRI. If it doesn't help, obviously, I have to escalate the treatment. Exam trap, a normal X-ray does not rule out hip fracture when the patient still cannot bear weight. I have a patient, my patient has history of fall, and after that, the patient cannot move his right leg, and it's externally rotated. So externally rotated and internally rotated is restricted. So in this case, I know this might be, and my patient has osteoporosis as well. So just to make things even worse. So the patient meets the criteria for pelvic fracture, but the X-ray doesn't help me. So does it rule out the hip fracture? No. I have to, and also the patient cannot even use that side. So I have to do the MRI. Scaphoid, I think we did cover this with very detailed. Usually the patient, the clinical clue that they give you a history of somebody that who is running, playing, or suddenly falling down, or someone, for example, get involved in a crash or whatever, he falls down on outstretched hand. So in outstretched hand, the patient develops pain, and if it is the radial side of the hand or the radial side of the wrist pain, and also not only that, the most important thing that they will include in the clinical vignettes, these are the clues. So if you see that in the scenario, you should be able to say that, yes, this is a scaphoid fracture. So the mechanism of the fall is whoosh, the radial side wrist pain, and anatomical snuff box tenderness right here. And scaphoid tubercle tenderness, pain with the axial thumb loading. So the best next step for me should be what? The thumb spica immobilization, right? And repeat the X-ray. Let's say if the X-ray is negative, it doesn't mean the patient does not have a scaphoid fracture. It means it might be negative until 2 weeks. So you can repeat the X-ray in 10 to 14 days, okay? And 10 to 40 days. In that case, if still the patient is not improving and you cannot see anything, and the pain and function of the patient, pain is there and the functionality of the patient hand is getting worse, then you can do an MRI or CT scan. But the first negative X-ray does not rule out the fracture, especially in a scaphoid. I don't know why they love to test you on this one. They give you all the clinical clue, all of them, except for the X-ray, which is normal. And then they will ask you, what is your best next step? The best next step would be the thumb spica embolization. And if they also include this in the scenario, what is the next step? To do a follow-up X-ray within 2 weeks or in 10 to 14 days. Or if the X-ray is not available or X-ray is not helping, then you do the MRI if things are getting worse. Do not discharge as a simple sprain. So if you have an X-ray negative and the patient completely have all the characteristic finding of a scaphoid, then you don't have to. You cannot just call it a simple sprain. Watch proximal pole avascular necrosis. So high yield complication, scaphoid fracture can cause non-union, avascular necrosis, and a chronic wrist arthritis. And that's why it is very important to immobilize the wrist. So low back pain when no imaging is correct answer. Acute mechanical back pain, no red flag. Do I have to do imaging? No. No red flag, no. Neurological sign and symptom, no pathological finding. I don't have to do any imaging. So most results, imaging often finds incidental changes. So unilateral radiculopathy, normal stent and reflexes. Do I have to do the X-ray? No. Why? Because I don't have neurological finding. I don't have the red flags. I don't have the pathological finding. MRI only persistent or progressive. Back pain, urinary retention and subtle anesthesia. Do I have to do X-ray? No. This is emergency. I have neurological symptoms. For neurological symptoms, I have to do an urgent MRI and I have to do urgent referral to surgery and decompression. Especially if the patient has metastasis, it is going to give it away. Back pain, cancer, obviously. Back pain, fever, intravenous drug user, IV drug user, always think about osteomyelitis or epidural abscess. For anyone, they just indirectly put it somewhere that the patient has, the patient will look toxic. The patient will look toxic, and the patient is IV drug user, and the patient has back pain. So what is the next step? They will put, for example, this, and the MRI would be the best choice. The best MCQ1 answer for uncomplicated back pain is often no imaging now, if there is no complication or no neurological sign and symptom or no red flags. But neurological cancer, infection, and trauma, red flags change everything. In that case, you have to go ahead and choose the MRI. So a spine MRI indication, cauda iguana, infection, cancer. Do I have to go through all of them? I don't think so. You guys know it, right? So cauda iguana, the patient will have urinary retention, subtle anesthesia, bilateral sciatica, reduced anal tone, progressive weakness. Best MRI, fever, infection, fever, injection drug, immunosuppression, severe constant back pain, ESOCRP will be high, and MRI. For cancer and hematoma, knowing malignancy, night pain, weight loss, these are very, very characteristic, and they love to use this. If you have these two words, always think about pathology. Either it is cancer or hematoma or abscess, okay? Anticoagulation after trauma, neurological deficit, and MRI. Urinary retention plus saddle anesthesia is cauda iguana until proven otherwise, so you have to do an urgent MRI. Now, Ottawa rules for ankle. The pain in mallular zone plus either. So when you guys are coming late, this is going to distract me. Bone tenderness, posterior edge or tip of the lateral malleolus, bony tenderness, posterior edge. I think I have a picture of it. Yeah. So this is a picture. You guys have it in your notes and orthopedics. If you go to Jala note, you would definitely find it. So this is very important to know because they love to test. So you would definitely get a question from Ottawa ankle rule, Ottawa knee rule, and Ottawa foot X-ray rule. So these, one of them will be in the exam, or probably all three of them might be in the exam, but they love to test you. I have seen it in all subscription, and I cannot insist more than this, that it is one of the most important thing to know and learn and memorize it and know it. It's not very hard, to be honest. It's not very hard. So the tenderness, and also for the foot, if the patient has this one. And the rest of them is almost the same thing. The patient should be able to take at least 4 steps in emergency room. If anyone who cannot take the first 4 steps or at least 4 steps in the emergency room, it means the Ottawa X-ray, whether it is foot, ankle, or knee, is indicated. Okay. So number 1, bone tenderness at the posterior edge or the tip of the lateral malleolus, or bone tenderness at the posterior edge or the tip of the middle malleolus. For the foot, any tenderness in the midfoot, navicular, and also 5th metatarsal, then you have to do the X-ray. Ottawa foot rule, I think we covered this and I showed you in the picture. So Ottawa ankle rule and Ottawa foot rules are separate. Malleoli requires ankle X-ray, and navicular 5th metatarsal requires foot X-ray. Don't get it wrong, please. Ottawa knee rule, this is the one that we haven't done it. So I made a very nice mnemonic for Ottawa knee rule and also MRI indication for the knee. I will show you, but let's go one by one and then I'm gonna talk about it. So for the knee X-ray, for the Ottawa knee rules, if the age is 55 and above, if the age is 55 and above, it is indicated. If the patient has knee pain with the isolated patellar tenderness, X-ray. fibular head tenderness, X-ray. Cannot flex the knee to 90-degree, X-ray. Cannot bear foot or take 4 steps, X-ray. No X-ray if the patient is younger than 55, if the patient can bear 4 steps, if the patient can flex beyond 90-degree, no patellar or fibular head tenderness, no red flag, no X-ray. But if this is the finding, obviously. Now, MRI, anterior cruciating ligament and meniscus suspected, MRI. X-ray negative but persistent instability, MRI. True locking, X-ray. Occult fracture concern, sorry, not X-ray, MRI. Management would change, obviously, MRI. Other knee rule decide fracture imaging. They do not diagnose ACL or meniscus. So for the ACL and meniscus, MRI. But if there is a trauma, it's always good to do the X-ray first, follow up with the MRI. Okay. So other knee rule. Okay. So for other knee rule, order knee X-ray after acute knee injury if any one of this is present. Any one of this is present. Let's say, so this is the mnemonic that I made, 55 path. For other knee rule, 55 path. So what is 55? 55 is the age. If your patient is age 55 and above, and P is patellar tenderness, if the patient has either 55 age or above, if the patient has patellar tenderness, if the patient has ambulation failure, it means the patient cannot take 4 steps, and if the patient has fibular head tenderness, and if the patient cannot flex the knee 90-degree, or the flexion of the knee is less than 90-degree. So this is for other knee rule. Now, MRI indication for the knee conditions. There is a mnemonic that's called locks. The locks, lock knee, obviously it's a true lock knee, you have to do MRI. O, occult fracture. C, cruciating ligament or cartilage or meniscus injury when MRI will change the management. And knee symptoms persist despite adequate conservative therapy. You don't find anything in the imaging, but the patient is getting worse and worse. So you need to do MRI, right? Serious pathology, suspect infection, tumor, osteonecrosis. So remember, what is other knee rule? 55 path. And what is the indication for the MRI of the knee? Locks. And it starts with a lock knee. All right. So limb threat, neurovascular compromise. When there is ischemia, obviously it is threatening the limb, the limb. So limb threatening clues. What are the clues? Obviously, we know the sign and symptom of ischemia, right? Absent pulse, pale, cold, foot and hand, whatever it is, delayed capillary refill, progressive paresthesia, motor weakness, severe deformity. Best immediate actions, what should we do? Fracture dislocation with ischemia, urgent reduction. So before we do any X-ray or anything, or it might take very long time, if there is no pulse and there's a reduction, we have to do the reduction to get rid of the obstruction or compression that causes the ischemia. Document neurovascular status before and after, which we did mention it. Image after reduction if the delay threatens the limb. If pulse stays abnormal, urgent vascular assessment, CT angiography if appropriate, and a specialist involvement. So if the pulse still, you do the reduction, and if it still stays the same, it is not working, there's no pulse, and the patient limb is still cool or pale, then you have to do an urgent vascular assessment, CT angiography, and involve specialist. Compartment syndrome, we have already discussed this. So this classic stem would be tibial fracture or crushed injury, pain out of proportion, pain despite the opioids, pain with a passive stretch. Remember, they love to mention this. This is a very, very important clue of the compartment syndrome. And tense compartment, pulse may remain present. We have already discussed this. Best answer, remove the tight, cast or dressing immediately if present. Keep limp at the heart level, not above. Urgent fasciotomy would be the best choice. Measure pressure only if exam unreliable. Late finding, pulseness, paralysis, pallor, permanent nerve injury, rhabdomyolysis, and acute kidney injury. So these are the late findings. Do not wait for the pulseness, because if the patient gets pulseness, it means the limb has been dead. The damage has been done. So we don't wait for the pulse to disappear. If you have a compartment syndrome and the pulse is still there or it's weak, so it means that you're not in the late stage. It is not too late. You have to act right away. That's emergency. But you shouldn't be waiting for the pulse to go away or the pulse to be absent. Okay, pulse gone, it means limp is gone. It means the damage has already been done. Pain with a passive stretch is an early high yield clue. Remember, this is very important. Remember this for the compartments, and they love to use this. And most of the time, it is in the scenario. So you should be able to pinpoint and know that this is compartment syndrome. Septic arthritis, monoarthritis, the patient will have fever. Again, for septic arthritis, the patient may or may not have fever. Okay, at early stage, the patient may not have fever, but any hot and swollen joint is septic arthritis until proven otherwise. So hot, swollen, painful joint, and severe pain with a passive range of motion. We did have this pain with a passive stretching for the compartment syndrome, right? Pain with a passive stretching for the compartment syndrome, and pain with a passive range of motion for the septic arthritis. And both of them are very commonly used as a clue. Very, very important clue of the septic arthritis, and also the passive stretching is the best and important clue for the compartment syndrome. Diabetes, rheumatoid arthritis, prosthetic joints, immunosuppression, synovial fluid test. Obviously, we have to test for the septic arthritis, or if you're suspecting, you have to check all the gram, culture, WBC, crystal, glucose, protein, and blood culture as well. Exam trap, X-ray may be normal and cannot exclude the septic arthritis. Aspirate urgently. For this, we don't worry about the X-ray. We have to check the fluid. So septic arthritis is threatening the joint. It is threatening the joint. And compartment syndrome is threatening the limb, the entire limb. Okay, so shoulder imaging dislocation, posterior dislocation, and rotated calf. So this is how they're going to give you the presentation or scenario when it comes to present cases about the shoulder, and if they want to test you on imaging of the shoulder. So they give you a stable anterior shoulder. What do? X-ray. They give you ischemic limb with dislocation. The patient had a trauma, or he was involved in a car or motor vehicle accident, and now the shoulder or the elbow, let's say the elbow is dislocated, but the patient cannot feel anything in the forearm and hand and fingers. And it is pale, it is cold, right? So what do? Reduce. Once you reduce, the compression should be gone and the blood supply and nerve supply should be resumed. So seizure plus internal rotation locked is usually axial view or CT scan, posterior dislocation. For the posterior dislocation, usually this is what they need you to know, that if you do the X-ray, you do the axillary, and also you do the CT scan for the posterior. For anterior, you just do the X-ray. Remember, for the posterior, you do the CT scan. It is not mandatory. You do the X-ray or the CT scan. But for the anterior, usually you do the X-ray on its own. Any question, please leave it for the end. atraumatic impingement, rotator cuff pain. No initial MRI, physiotherapy. Obviously, if it is not traumatic, it is impingement, it is rotator cuff pain. So for that, there is no tear. If there is no tear to the soft tissue, we don't have to do an MRI, right? We have to do the physiotherapy. So traumatic, now it is trauma, persistent weakness, and the patient has drop arm. What does it say? It means the tendon or the muscle has been ruptured, or there is a rupture of the tendon or the muscle. Most likely the tendon, right? So in this case, what do? I have to do the MRI after X-ray. Why after X-ray? Because first there is a trauma. When there is a trauma, I have to rule out the fracture and then dislocation. And then I do the MRI because the X-ray is not going to help me with these tear and ruptures. So for that, I have to do MRI. X-ray is going to help you with the fracture and dislocation. MRI is going to help you with the rupture or tears. Post-reduction rule, repeat X-ray and neurovascular examination after reduction, always. Knee MRI. So I think for the knee MRI, we had a mnemonic. What was that? Locks. Let me take you back to that slide. Yeah, here. So locks. Lock knee, ankle fracture, cruciating ligament, cartilage, meniscus, knee symptoms persistent despite adequate treatment, and serious pathology. Here we go. So how they're going to give you scenario or the clinical vignettes. Now, you have a patient who had pivot injury, plus he had a pop, plus swelling in the knee within 1 to 2 hours, plus Latchman test is positive. So if you have a knee trauma and the patient has swelling right away, and within 1 to 2 hours, and when you do, and the patient also had the pop, this is very important. The patient had the pop, swelling happened, and it happened rapidly, and Latchman test, which is the most specific test for the anterior cruciating ligament, it is positive. If it is positive, obviously it is anterior cruciating ligament. So X-ray first, if the trauma is there. If there is trauma, always we have to do the X-ray first. Why? Because we have to rule out the dislocation and fracture. Then MRI is going to give us more information about the rupture or the tear, right? Now, you have another patient which has twisted knee. I mean, the knee was there. It was planted on the ground, but the foot was planted on the ground, but the knee twisted. The knee twisted, joint line tenderness, very important, joint line tenderness, catching, locking. So what is it? Remember, if you have pain in the knee, but then the pain is in the joint, and there was a twisting of the knee, it is meniscus. And also the patient has the catching and the locking, which is the meniscus. For the meniscus MRI, if true locking or persistent management, changing symptoms. Mild anterior knee pain plus stairs setting plus no effusion. Patellofemoral pain. Do I have to do an imaging? No. No routine MRI or X-ray. Or older adult with osteoarthritis, degenerative meniscal finding. Osteoarthritis dominates management. Treat functions first. Avoid routine arthroscopy. Large effusion after trauma. This is different. Large effusion after trauma plus fracture concern. So obviously, if there is a trauma, then there is a huge effusion. I am thinking about serious injury. So I have to rule out the fracture. So internal derangement or occult fracture. So I have to do X-ray. So I am concerned about the internal derangement. So I would continue and do a follow-up MRI if I'm not happy with the X-ray finding. MRI is not subtitle for history and physical examination. Order MRI when result will change the plan or the treatment. Now, pediatric orthopedics, which yesterday we did cover this, right? The 5 Fs. If you have the 5 S, so what do? If it is less than 4 to 6 months, ultrasound. If the patient is more than 6 months, X-ray, and plus you have to refer it to the specialist. You have adolescents, obese, knee and hip pain, and the patient is limping. What is it? SCFE, right? So anterior, posterior pelvis plus lateral hip, and I have to send the patient to orthopedics for the surgery. Now you have another patient which is 4 to 8, gradual limb, limited the hip and internal rotation, and the patient pain is less and the age is less too. So what is it? The prothese. So what do? I do X-ray, and if I'm not happy with the result or it's not giving me enough information, I can follow up with the MRI. Classic nursemaid elbow after traction. If it is classic, it means there is no tenderness. There is no tenderness point. There is no swelling. There's no bruising. There's no cut. There's no bleeding. This is called classic. And there's no injury like fall, trauma with the car or crash. So it is just traction. This is called classic nursemaid elbow. What do I do? Reduction. Do I need to do any X-ray or imaging? No. But if I have a nursemaid like plus swelling, plus tenderness point, plus bleeding, or plus suspicious of fracture, of course I have to do an X-ray, right? Fever plus refuse to bear weight in the hip, especially kid, it is septic arthritis until proven otherwise. Any pediatric population or patient who refuses to use the joint or refuses to bear weight, and he has swelling, hot, painful joint, and refuses to walk on that joint or that limb, it is septic arthritis until proven otherwise. So what do we do for the septic? Aspiration. So pediatric rule, atraumatic pain, knee pain with a limb often requires hip examination and hip management as well. So this is something that we covered yesterday, right? The DDH, the developmental dysplasia of hip, SCFE, prothese, osgood, and patellofemoral syndrome. So when no imaging is the best answer, uncomplicated, negative Ottawa, classic nursemaid, and typical osgood, typical patellofemoral. What to do next? Educate the patient if it is uncomplicated, right? You don't have to do X-ray. Just have to educate the patient. If it otherwise negative, just do functional rehabilitation. Again, for knee, if Ottawa criteria does not meet, analgesic when safe. If it is clear, classic, nursemaid elbow, you have to do the reduction. And also you have to educate the parents. Osgood, again, follow up with persistent worsening symptoms, but you have to just do the conservative treatment and functional rehabilitation. Return precaution, if you have pain, this is very important for those of you who are doing NACOSCI. These are very important part of the consultation, that you have to let or educate your patient that this is what we are doing. But when you need to come back to us, if the patient or if you're the patient, or if the baby is the patient, now you bring the baby. If the fever happens and inability to bear weight, progressive neurological deficit, true locking, night pain, weight loss, new deformity, or ischemia sign, then you bring it back, or you have to go to the nearest emergency room or hospital. Avoid unnecessary imaging. Did I change it? Yeah, I think I did. Avoid unnecessary imaging is a high quality care only when red flags have been actively excluded. All right, so orthopedic red flags. So when we have the red flags, obviously there is indication for the investigation or for the imaging, right? So absent pause, all the ischemia sign and symptom, pain out of proportion, compartment syndrome, septic arthritis, cauda iguana, metastatic compression, spinal infection, bone tumor. So if it is vascular compromise, urgent reduction reassessment, if it's compartment, fasciotomy, if it's septic, arthrocentesis, cauda equina, urgent MRI, metastatic compression, again MRI, spinal infection, again MRI, urgent bone tumor pathology, X-ray first, then advanced imaging or MRI. Now, best next step algorithm for MCQ1. Is the limb ischemic? Remember, these are the questions that we have to ask. These are the questions what we have to ask ourselves, and based on that, decide. My patient has a limb injury. Is there any limb ischemia? Yes. Reduce. If there is a dislocation, reduce it. Do a reduction and check for vascular. Is the joint infected? Yes. Do aspiration. Is the spine, does the spine have red flags with it? Yes. Do MRI. Does it, is there a traumatic fracture? Yes. Or is there a trauma involved in this condition? Yes. Do an X-ray first. Now, other negative, just do functional approach. So these are all repeated. Same phrase. Now, this is how they're gonna give you an example. I think we did cover this part, right? We did cover it, yeah. We did cover this part. We did cover that part as well. So first MRI, we did this as well. Yeah, this is the one that 55 path is for the other one, knee rule, locks is for the MRI indication for the knee. And thank you very much. Let's do a few cases.